Good afternoon, good morning, good evening, colleagues, wherever it is that you're joining us from. Welcome to this session today. We are going to talk about economic and programmatic implications for COVID-19 vaccine rollout in Africa. My name is Ahmed Ogwel Uma. I am Deputy Director at Africa CDC, and I would like to welcome all of you who have found time to join us today. We really want to have a good, vibrant discussion during this session. We as Africa CDC are very delighted to be co-hosting this event today with the African Health Economics Associates here. And we hope and look forward that this is just the beginning of many more joint and collaborative sessions across many months in the future. Allow me to say three things. The first is that Africa CDC is a specialized agency of the African Union. And indeed, our work is underpinned by the Africa Union's Agenda 2063 and also the vision that our heads of states had in securing Africa from all health security threats. And that's why Africa CDC was formed. We are only 4.5 years old, yet we are doing quite a bit, much more than a young organization like ours would have been able to do. One key area that we would like to strengthen is health economics. And we have set up a unit within Africa CDC. We are engaging with our partners and particularly our member states. We are engaging with other partners who are non-state actors to ensure that this health economics unit provides the support within the mandate of Africa CDC that had been envisioned. We will work very closely with all of you to ensure that we meet our objectives. Today's topic around the COVID-19 pandemic is very important, particularly because the economy has been hit from many sides, some very direct because of the virus and its effects, and some a little bit more indirect because the economy is part of a bigger ecosystem. And we would like the health economics conversation to capture all these different aspects. At the end of today's session will not be the end of the conversation, and we have a very wonderful group of speakers that are going to help with us understanding issues around health economics on the continent in the context of COVID-19 vaccination. We are really delighted that we have such an honorable group of speakers, as we will see shortly. I would like now to pass it on to Javier Guzman to make remarks. Javier.
Thank you very much, Dr. Ahmed, and hello everyone. My name is Javier Guzman, and I'm the Director of the Global Health Policy Program at the Center for Global Development. And it is a pleasure for us to be here with the Africa CDC and AFIA hosting this event. We know COVID vaccine global inequity is the biggest global health issue of our times. And we've seen how policymakers have faced the challenging task to set priorities and allocate limited resources effectively with strained budgets and with supply shortages. And as Dr. Ahmed said, in this difficult environment, Africa CDC has been at the forefront of the fight against COVID in Africa. And AFIA has championed the need to include health economics evidence in the decision-making process. That is why today I am here to celebrate the creation of the Africa CDC Health Economics Unit. I remember how a few years ago, with the support from the Gates Foundation, we, CGD, began working with the Africa CDC to establish a group that would support them to incorporate economic evidence in decision-making processes. And now the Health Economics Unit is a reality. It is small, but it's growing. And we're delighted to keep supporting the unit to develop its full potential. Today we have, a very interesting conversation of work the Health Economics Unit is been doing with, key partners like the London School of Hygiene and Tropical Medicine, the University of Nigeria, CGT, and others. And going forward, we very much hope the Health Economics and the Health Economics Unit will play a critical role in driving public health in Africa, supporting the African Union and its member states for a healthier and more prosperous continent. So welcome and thank you. And over to you, Dr. Ataguba.
Very many thanks. It's a pleasure to have everyone here. I am John Ataguba, currently the Deputy Director of AFIA. AFIA is the African Health Economics and Policy Association, an umbrella body of health economists on the continent. And I'm also a professor at the University of Cape Town. For me, this is a very important point for us to keep in mind. We've highlighted the issue of inequities in terms of access to vaccines, not just in Africa, but the developing world generally. We, as health economists, have known previously, and we still kind of knowing, that we have challenges with accessing health services across countries. And we know that health services should be based on need, not necessarily based on finances or power. But unfortunately, we still keep repeating the same thing over and over again. Here comes the vaccines for COVID-19. The distribution follows the power lines. It still follows the wealth lines. We still have this challenge that we yet to surmount. And we clearly know that Africa has a high burden of disease. We are unable to produce vaccines on the continent due to stringent patent rules that have been set, and also issues to do with licensing. Currently on the continent produces less than 2% of vaccines that are used within the continent. And if you understand the context of the continent with a high burden of disease, we should be producing vaccines, but it's not happening. So I think having this forum to discuss and also to engage with key stakeholders would provide an opportunity for us to begin to think through how we can address this challenge, and more importantly, put Africa first and address the needs of the continent. And I will argue that if you address the needs of the continent, you reduce disease burden. And of course, many developed countries would reap the benefits of lower disease burden on the continent. So with that, I thank you, and I wish you all have a wonderful stay here. And AFIA is really proud to be part of this. Thank you. I'll pass that to back to, let me see who the next person is. Sorry, Ahmed, please. Thank you.
Thanks, John. Thanks, John. And both you and Javier, thank you very much for your comments. And it's really a pleasure for Africa CDC to be co-hosting this event today with both CGD and AFIA. Now let's turn to the core part of our meeting today. I would like to first share that the way that the session today will run, we'll first have a keynote address. And then after that, we are going to have two other expert presentations before we move into a panel. And for the keynote address, today we are honored to have with us Dr. Donald Kaberuka, who is very senior and well-renowned African working for the continent in various capacity. Today I will mention only two. One that is the AU's Special Envoy on COVID-19, and also the AU's High Representative for the Peace Fund, financing the Union, as well as health financing. So he's right on spot to be able to unpack for us issues around the economics of COVID-19 vaccination rollout on the continent. As we listen to Donald and questions do come up, we encourage you as participants to do send your questions so that we can be able to have responses to them at time allowing. So it is my honor now to invite Dr. Donald Kaberuka to speak with us as a keynote speaker for today. Dr. Kaberuka, you have the floor.
Thank you, Ahmed. Thank you, colleagues. I hope you can hear me loud and clear. Very good, thank you. Good afternoon, everyone. I'm really pleased to be here among friends and colleagues, the many experts, health economists who are here. Let me join the moderator in saying how proud we are of Africa CDC and what it has done in a very short period of time. The very existence of this health economics unit is testimony to what proud of place CDC occupies at this time. So I want to thank John and Ahmed and colleagues in CDC for what you do. So let me go straight to the point. You know, an assessment of the last 2 years must begin with the dreadful fact that more people have died of infectious diseases, maybe since the Spanish flu. There is reason to believe that, driven by the Delta variant, COVID-19 has claimed more lives directly, probably far more than is officially recorded. This is not to mention the knock-on effects on other pandemics like HIV, TB, and malaria, where the gains of the previous years have been reversed. I wanted to add, Ahmed, this. I also happen to chair the board of the Global Fund for HIV, malaria, and tuberculosis. And I can tell you that COVID has been a major setback to these efforts. And therefore, until such a time that enough vaccines are deployed, the threat of COVID will not be over. Even then, we cannot rule out the emergence of new and even more deadly or transmissible variants. This is why, therefore, I recommend the organizers of this event who are going to look into the economic and the programmatic implications of this pandemic. I mean, as all of us know, as experts will be pointing out, the more people we can vaccinate, not only fewer mortalities, but there will be less economic losses, and we shall be able to reopen fully our economies. Now, how best this is done within a fiscally constrained environment in specific landscapes is what you're exploring today. And I look forward to learning from you on that one. Needless to say, vaccines have been a challenge, as Ahmed was saying. Even when vaccines were available at the beginning, when we had the money, we could not access the vaccines. Even when they were accessed, even without subsidy, such as COVAX, the cost is up to $10 per dose. Now, this will squeeze the fiscal space and other expenditures, but the human and economic benefits are there for all of us to see. Here in Rwanda and my country, good progress have been made on vaccination. We are on course to vaccinate 90% of the people in the capital city, and hopefully 40% by the end of the year. But we're one of the few countries, with Morocco and Seychelles and a few others. Today in Africa, on average, fully vaccinated people are less than 4.4%. Only 15 out of 55 countries have achieved the 10% target. Compare that with the UK, 66%, EU, 62%, US, 52%. So why are we falling behind? We are falling behind because of a combination of factors. First of all, African states relied at the beginning a lot on a combination of bilateral deals, donations, COVAX vaccine sharing scheme. Our countries struggled to get supplies, even via COVAX. A lot of promises have been made at a global level, but of the more than 1 billion doses promised, less than 15% have been delivered. To reach even a minimum of 10% would require 270 million doses. I do want to commend the African Union and Africa CDC again for setting up AVAT, the African Vaccine Initiative, which has been instrumental in filling, to some extent, some of the gaps. Now, in May 2021, Dr. Tedros, head of WHO, set up some global targets, well known to you. 10% by September, 40% by December, and 70% by mid-2022. This is what it will take to fully protect our people and to open our economies. Now, beyond vaccine shortages, there are also operational bottlenecks. Now, which countries like Morocco, countries my own, have been able to overcome by adopting innovative vaccine delivery mechanisms. I'm very encouraged by the progress on the vaccine manufacturing side. Already, Senegal, Rwanda, South Africa, Morocco, and a few others we're making progress there. It is important that what we have seen in the global supply chains, whether it is diagnostics, therapeutics, or vaccines, does not happen again. Africa must be prepared in the future for those pandemics by manufacturing those things around the continent. The economics of vaccination, or vaccine production, or pharmaceutical production as a whole, I will know. But sometimes the cost of action can be seen to be high, but the cost of inaction can even be higher. So I look forward to learning from you today, colleagues, on these issues. And I want again to thank you for organizing this event, and again to thank CDC and Health Economic Unit for bringing us together. I thank you, and I wish you well. Thank you, sir.
Thank you very much, Dr. Donald Kaberuka, for setting the stage for this conversation today. Very incisive presentation there with figures that should really make us on this continent and those who love Africa to rethink the way in which we are approaching this pandemic. So thank you very much, Donald, for that very clear message. I would now like to invite two colleagues to give us some expert presentations. And I will call upon them to really try and stick to the time so that we can get some feedback from the audience. And first, I would like to introduce Mark Jitt. And Mark, if you can be able to introduce yourself before you make your presentation, I think you will do a lot more justice to explaining your work at the London School of Hygiene and Tropical Medicine. So first is Mark, you have the floor.
Thank you, Dr. Ahmed, and thank you so much for inviting me. I feel very honored to be speaking after such a panel of very illustrious speakers who have given us an excellent background to the problem that we're facing. So just to let you know a bit about me, I'm a professor at the London School of Hygiene and Tropical Medicine, and my work has been mainly about mathematical modeling and economic analysis of vaccination programs. So in the last 18 months, I've been really focusing on COVID-19 together with colleagues around the world. So that's what I'm going to talk about today. Let me share this presentation. Really, together with colleagues at Harvard University at the Center for Global Development, and really importantly, our colleagues at Africa CDC, like Dr. Justice and others at the Health Economics Unit, we've been asking how can health and economic modeling really help to support the decisions that are being made across this continent of Africa. And today I'm going to speak a bit about how this evidence can be used and what kind of evidence has already emerged and what kind of evidence might continue to emerge. And my colleague, Dr. Farana, will then be following on from that to talk about some work being done led by Harvard University. So I was going to start off by setting the policy importance of this work, but I think Dr. Kaberuka and many of the colleagues who came before me have really painted this picture very well. We are in a situation where there is, well, both really constrained supply of vaccines and also very unequal distribution of vaccines, unfortunately. And so, I mean, here are some projections from COVAX, which is underlying the sort of figures that Dr. Kabruka pointed out, really showing that the percent of the population that can be vaccinated who in the countries relying on COVAX will only gradually start to increase in 2022. So countries are having to make really hard decisions about, with this very limited, this precious supply of vaccines, how do we best use it? And also make the case that actually countries need more vaccines. And so what will be the benefit of having a better supply of vaccines? On the other side, there's maybe the opportunity to buy additional vaccines outside the COVAX facility, but the prices for these vaccines are actually considerable. And there's lots of differences between different vaccines, different prices, but the vaccines are also not identical. So these are the challenging questions that are being asked. How do we answer these questions? And actually, one route is to use health and economic modeling. And so these are the kinds of questions that are being asked by different people in different sectors that health and economic modeling can address. For instance, in terms of people's lives and health, people might want to know, decision makers might want to know, if I use this vaccine, how many lives am I going to save? How many cases of COVID am I going to prevent? Or maybe we're also interested in the healthcare sector. We're thinking our healthcare sector, the hospitals are really being stretched by COVID. If we introduce this vaccine strategy, this vaccine to this group of people, how many hospital beds will it free up? How many healthcare workers will be freed up? But on the other side, if the healthcare budget has to fund these vaccines, will it displace other important healthcare investments? So can we afford it as well? Being able to balance these considerations in the healthcare sector. And then moving beyond the healthcare sector and looking at the families, the households who are affected by this pandemic, asking, well, will this vaccine strategy stop poor families from being driven further into poverty because they're having to pay out of pocket for treatment, to access care, and also because they're unable to work, they're not able to earn an income? And so looking at some of those questions, and then also looking at the broader economy. COVID has affected all our economies in Africa and Europe, and really asking, well, can vaccination help our economies to recover? What will be the change? What will be the improvement in national output, in gross domestic products, if we are able to introduce different vaccine strategies? So both London School of Hygiene and Tropical Medicine and Harvard University are working with colleagues in Africa CDC and in different countries in Africa to try to address these different questions. And I put some logos to show the particular areas that the two groups, London School and Harvard, are focusing on in this area. But let me start by giving some idea of some of the evidence we have so far as we are working with these different countries to answer some of these questions. For instance, one question is, well, what is the ideal group to vaccinate? If we have limited vaccine supply, who should we target? And which, well, first of all, which of these vaccines should we use? And one of the conclusions from these modeling strategies is actually, if the stage is actually to give targeted protection to the people at highest risk, then actually the most effective strategy is to prioritize giving even just one dose of the vaccine to as many people as possible, even if it's a cheaper vaccine, which might be less effective against milder infection. It will still give good protection against severe disease, against death, and even the first dose will give a reasonable amount of protection. So get as many first doses out as possible and then start giving the second dose. As countries start to move towards transmission reduction, then they need the more effective vaccines, like maybe the mRNA vaccines. They need to think about prioritizing the second doses, because the first dose will not give good protection against infection. So for transmission reduction with a broader strategy, then the kind of vaccine that gives the most value, the most bang for the buck, the most value for money might change. So that's one question that we and others have been looking at across different settings around the world. Nigeria and Africa, as well as countries on other continents as well. Second of all, how much should we be paying for these vaccines, given that these are countries with really very health budgets that have to stretch a long way to address many different infectious diseases and non-communicable diseases? And so the analyses that have been done in several countries really show that at COVAX prices, both the standard price as well as the option to have more vaccines at more flexible vaccines at both these prices, these are very good values, even if they're funded through the health budget. At the sort of 160 to 310 a dose, the value of these vaccines in terms of saving lives, in terms of preventing healthcare costs, they provide really good value. As we go to the non-COVAX prices, which can exceed $10 a dose, then if these are funded from the healthcare budget, then the value of the healthcare investments in this place might be greater than the value of the vaccines. But actually, these vaccines also have value beyond the healthcare sector to the wider economy. So if they can be funded outside the healthcare budget, then even these higher prices might still be worth paying. But if they're funded from the healthcare budget, then the COVAX prices are the ones that countries should be aiming for. Another question that different groups and different investigations have looked at is actually what is the best strategy to use in order to really reach different outcomes? And really the question is, what is the aim of the vaccine strategy? If it is to minimize the number of deaths, then the first priority really is to vaccinate the highest risk population, especially when supplies are more limited. But then if the goal has expanded to minimizing cases or minimizing disability in the population, both long-term and short-term disability, then actually the program can switch to vaccinating the high transmitters. And these might be younger people who might not be at so high risk for severe disease, but who are maybe economically more active, maybe meeting lots of people. And these are the people who we might want to protect from spreading the infection. So these are some of the sort of like key messages that we've got from working with different countries so far, with thanks to this collaborative work with the colleagues in different countries. I mean, the other question is asked is, well, how do we use this information? And it's great to work with different colleagues as they're thinking of how to use this evidence. It's as part of a sort of wider HTA process. And so one of the pieces of work we're doing next is to do a continent-wide analysis to look at different rollout strategies and say, well, what is the health loss due to scale-up delays, for instance, in the continent? If Africa is not able to get enough vaccines on time, what is the impact it might have on health and on economies? Actually making the case that, well, actually, if we are able to ensure better supplies, greater supplies of vaccines, what will be the benefit? And also, given the supplies, what is the optimal vaccine strategy to use given different supply scenarios? It's also been great to be able to work with colleagues as they're thinking through how to use this evidence. And often it's through a health technology assessment process. The economic work, the disease modeling work is crucial pieces of evidence to inform that. But it's also part of many other pieces of the puzzle, which are combined with values that different countries and Africa CDC also might have about choices, about the trade-offs between things like health and the economy and the individual's ability to start going back to normal life. And so bringing in other disciplines as well into the decision-making. So I was asked to say a bit about how this will all fit into a decision-making process. And this is one model that has been used around the world by WHO and in different countries, really bringing together the experts in different areas, including the modeling, including the economics, but also the epidemiologists, the scientists, the people who understand human nature, human behavior as well, and then coming together in a deliberative process, together with patients as well, to the public, with the people delivering the vaccines and the healthcare, and having a process that's understandable by the general public so that they understand what evidence is being discussed. It's a transparent process. The minutes are discussed. This might be the NITAG, the National Immunization Technical Advisory Group. It might be the special task force set up to deal with COVID. It might be the HTA body. And then being able to present the advice to the final decision maker, whether it's the ministers, whether it's the Africa CDC, the senior leaders of Africa CDC, who can are able to say, well, we considered this evidence that the advice that the expert gave, it's all transparent, it's documented, and here's the decision that we finally made as the final decision maker. So this is the role that I think modeling and health economics can play in this process, and some of the conclusions that we've reached so far, but there's more to come. So really glad to be able to talk to you about this, and I'll hand back either to my colleagues now. Thank you.
Right. No, thanks. Thanks a lot, Mark. Very, very clear there. The message is we need to use more modeling so that we can be able to prepare better, and then utilizing, of course, the knowledge that we already have. Very clear message there, and I'm glad that you are part of the panel that is giving us some very good information. Let me remind all our attendees that if you have questions for our panelists, please submit them to the email address that will be shared. It is events@cgdev.org. If you want to tweet, you tweet at cgdev. Hashtag is CGD Talks. Or you can submit your comments on the YouTube channel as well. We will pick those up and we get responses from our experts. And thank you, Mark. Now let me introduce Madalena Ferrana, who will, of course, introduce herself a little bit more than I, so that we get to hear and know what areas she's covering at the Harvard School of Public Health. And she'll be presenting to us health and economics benefits of COVID-19 vaccine allocation. So Madalena, the floor is yours.
Yeah, thank you. So, well, first of all, let me thank the organizer of this event for inviting me to present on the work that I'm doing currently on COVID-19 vaccination. And it's a real honor to be in this panel and to be able to give a few the results that we are developing. So just as a way of introduction, my name is Madalena Ferrana. I'm an economist and a research associate at the Harvard School of Public Health. And most of my current work is focused on estimating the full value of vaccination, and in particular assessing what are the broad health and socioeconomic impacts of vaccination. And what I'm going to present today, I will share some results on a project on COVID-19 vaccination, which is supported by the Bill and Melinda Gates Foundation and carried out in collaboration with my colleagues, Daniel Cadret and David Bloom. So the overall objective of this project is to assess the health and macroeconomic benefits of alternative COVID-19 vaccination strategies that differ in terms of scale, speed, and demographic focus. And as Professor Jitt already mentioned, the project is complementary to the one carried out by the London School of Hygiene and Tropical Medicine. And particularly on the economic side, the work of Professor Jitt and colleagues focuses on the healthcare sector and the macroeconomic effects of COVID-19 vaccination, while our work focuses mainly on the economy-wide benefits of COVID-19 vaccines in terms of effects on gross domestic product and economic growth. And I just want to say, first of all, that the main results of our work is that the macroeconomic impacts of COVID-19 vaccines are substantial, and particularly they depend on the chosen vaccination strategy. So it's important to think about the different aspects of COVID-19 vaccination, because that will have not only health impacts, but also substantial macroeconomic impacts. And as was already highlighted, for instance, by Dr. Kaberuka, COVID-19 has had devastating health consequences throughout the world in terms of heavy death tolls, overwhelmed health systems, and disruptions to routine immunization and primary care. And the experience with COVID-19 has also made self-evident that protecting the health of the population is good for the economy and its future trajectory. So the slide here presents a selection of the most salient socioeconomic benefits of COVID-19 vaccination. First of all, we can think that thanks to COVID-19 vaccination, children around the world will be able to attend school more regularly. And indeed, the school closure has been a widely adopted measure to control the spread of the disease. And the positive impact of schooling on individual lifetime income and economic growth is, of course, well documented. A second possible benefit of COVID-19 vaccination is related to working age adults. So vaccinated individuals will be less likely to become ill, and as a consequence, they will be better able to work and to undertake productive no-market activities, such as childcare or volunteering. Third possible benefits is the fact that once a sufficiently large number of individuals is vaccinated, restriction on social and economic activities can be relaxed. And indeed, the countries throughout the world have had to rely on costly non-pharmaceutical interventions, for example, closures of economic sectors to control the spread of the disease. And as Dr. Kabaruka was reminding us, with vaccination, these interventions can be lifted, and this will allow economic recovery. In addition, changes in national and international consumption patterns for fear of infection have contributed to the economic contraction. And so vaccination can stimulate spending both by increasing household income and also by reducing this fear of infection. So to assess both the health and macroeconomic benefits of COVID-19 vaccines, we built an integrated epidemiological economic model. And the epidemiological component provides country-specific estimates of infection, hospitalizations, and deaths with and without vaccination, given the country's socio-demographic structure, local COVID-19 pandemic epidemiology, and the structure of the economy on the healthcare system, and the characteristics of COVID-19 vaccines to be distributed. On the other hand, the economic component measures the short-term GDP losses with and without vaccination. And these losses are associated to, for instance, shortages in labor force due to cases of severe disease and deaths, economic restrictions imposed by the government to control the pandemic, and changes in consumption patterns due to fear of infection. And the interesting thing is that the economic and the epidemiological components are mutually dependent. So for instance, the state of the pandemic affects the economy through the channels that I just described. And in turn, the economic structure, so for instance, the number of people that can work from home, and the changes in social and economic activities through non-pharmaceutical interventions will affect the spread of the disease. And we have applied this model to different countries using country-specific data whenever possible. And here is a list of the countries that we have considered so far, including a few countries on the African continent. And I have to say that these simulations are a result of collaborations with the World Bank, WHO, and Gavi. So what I'm going to do now is to present a few general results of the model. And these results actually, they don't apply to any of these specific countries, but they refer to a typical low-income country setting with a population of about 30-40 million people. So one of the questions that we have been asked to address concerns the desired vaccination coverage and speed of vaccination rollout. In particular, what are the incremental health and economic benefits of vaccinating increasingly larger share of the population at a faster pace? And to answer this question, so we assume that the administration of vaccines follows the age descending order recommended by the WHO. That is, first, older people are vaccinated, and then progressively younger people are vaccinated. And given this allocation rule, we considered 4 different coverage levels. So the first coverage level assumes that only individuals age 50 and older are eligible for vaccines. In the graph, this would correspond to the 50+ strategy. The second coverage level assumes that the vaccines is given to individuals age 20 and older, so the 20+ scenario. And then the third coverage level assumes that the vaccine is administered to adolescents and adults. This will be like the 12+ strategy. And finally, the last scenario is the case in which the entire population is eligible for vaccination. This will be the 0+ strategy in the graphs. And also we consider 2 different speeds of rollout. What I call a fast rollout is the assumption that all eligible individuals are vaccinated within 6 months, while in a slow rollout, eligible individuals are vaccinated within 18 months. And the slide here shows for each combination of coverage and speed, the number of COVID-19 deaths on the left and the associated macroeconomic cost in terms of GDP loss compared to a no pandemic scenario on the right. And we also estimated the number of deaths and economic cost if no vaccine is administered. This will be like the red bar. So the graphs clearly show that both coverage and speed matter. And indeed, the larger the number of people who are vaccinated, the larger the number of deaths averted compared to a no vaccination scenario, and the lower the total GDP loss. And similarly, a fast rollout leads to better health and economic outcomes compared to a slow rollout. So the overall idea of these results is that the faster you can vaccinate and the more people you can vaccinate, the better it is both from a health point of view and also from economic point of view. And an interesting result is also the fact that the simulation here shows that you need to vaccinate at least individuals aged 20 and older to reap off most of the health and economic benefits of COVID-19 vaccines. If you vaccinate less percentage of individuals, you still get sizable health and economic benefits, but you can do better by vaccinating at least the 20 plus. And extended the vaccination to younger individuals confer additional health and economic benefits, but these are actually proportionally smaller benefits. And the second exercise that we performed concerned the vaccine prioritization strategy. So the WHO recommends an age-based rule that after frontline healthcare workers prioritizes older individuals because of the expected large health benefits this would create, as Professor Jitt just explained a few minutes ago. And indeed, given the relative effectiveness of existing vaccines against death and transmission, direct protection of those that are most at risk of severe disease and death is deemed to be the best strategy to minimize the number of COVID-19 deaths. However, there might be also an argument for prioritizing individuals who are critical for the flourishing of the economy. And according to this argument, prioritizing economically critical individuals would allow them to return to work and resume consumption activities sooner, thus speeding up the process of economic recovery. And in this exercise, we were interested in assessing how these approaches fared in terms of both health and economic outcomes. So in the simulation, we compared two different prioritization strategies. The WH-based rule, that in the graphs here is represented by what I call the elderly rule, and the rule where working age individuals are vaccinated first and then the older population, so the working age scenario in the graphs. And this latter rule represents the idea that economically critical individuals should be prioritized to speed up the economic recovery. So you might want to vaccinate first the individuals at a working age because they have a critical role, a critical economic role in the society. So it turns out that the WHO age-based rule prevents more deaths without actually compromising the economy. That is, the gross domestic product loss is comparable to what is seen when the working age group, that is the economically critical group, is prioritized. And you see that on the graph on the right, sorry. And this result is due to the link between the introduction of restrictions to economic activities and the severity of the pandemic. And in particular, as reflected by countries' experiences, we assume that non-pharmaceutical interventions are triggered by the surge of infections and hospitalizations, with the goal, among other things, to prevent overburdening of the healthcare system. So prioritizing the high-risk population, the elderly in this case, prevents the most deaths, prevents the most hospitalizations, and also, as a consequence, reduces the need to adopt costly non-pharmaceutical interventions. And this is the reason why the economic benefits of an elderly age-based rule that prioritizes the elderly are comparable to actually the economic benefits of prioritizing the working age population. And in addition, from this slide, notice how what I call a random allocation. So a random allocation will be the case in which there is no prioritization at all. This kind of allocation actually performs worst both in health and economic terms. And this highlights the importance of thinking systematically about how to allocate vaccines. So to summarize, COVID-19 vaccines confirm a multiplicity of health and socioeconomic benefits. And if we apply the model to a typical low-income setting, we show that there are larger health and economic benefits when vaccinating a larger share of the population at a faster pace. And we show also that the WHO age prioritization performs well both in health and economic terms compared to alternative allocation rules, and particularly compared to a rule that prioritizes individuals that have an economically critical role. And it should be noticed that the benefits of vaccination that we estimate are conservative because actually they don't include all the possible benefits of vaccination. For example, they don't include the positive impact of schooling because this is going to have more like a long-term impact. They're not going also to include the positive impact on global supply chains, on savings or capital stock, or on mental health. And the main message of our work is that the vaccine prioritization strategy in terms of scale, pace, and focus is naturally guided not only by health considerations, but also by economic considerations. And thus, it's important to carefully account for the economic implications of alternative vaccination strategy. And what I presented today were just general results for a typical low-income country. However, the identification of the optimal vaccination strategy is country-specific and will depend on a variety of factors, including, among other things, the socio-demographic and economic structure of the population, the characteristics of the vaccines to be distributed, and the policy goals of interest. So, for instance, if the policymaker is more interested in minimizing deaths or in reducing the economic disruptions. And we are currently working on the design of a user-friendly simulation tool that will allow users to easily compare the epidemiological economic implications of alternative vaccination strategies in their countries. And this tool hopefully can help guide policymaking related to COVID-19 vaccination, both at the national and international level. And as soon as it is developed, we would be very happy to share it with anyone who is interested. So thanks for listening to me, and I'm looking forward to see if there is any comment or question.
Thank you. Thank you very much, Madalena. I usually like simple messages. What I'm hearing from you is vaccinate as many as possible in a short period of time. And then 20 sounds like just the right age to be able to do that. So all the other nice things that you've said, I've come out with this too, and I'll be amplifying that message as much as I can as we wait for your tool to come out and we can be able to share it broadly. And I hope my colleagues in the Health Economics Unit of Africa Union, the Africa CDC and the Africa Union, they are listening. We need some of this evidence to be generated from our side. So thank you very much to the two colleagues, Mark and Madalena. I would like now to shift to Ama Feni, who's going to moderate a panel discussion. So Ama, the floor is yours.
Thank you very much, Dr. Ahmed Ouma. And a warm welcome to our panelists today. My name is Ama Feni. I'm a senior research fellow at the University of Ghana. Today with us on our panel, we have Dr. Edith Kwasi. She's a technical advisor to the Minister of Health, Public Hygiene and Universal Health Coverage in Côte d'Ivoire. Then we also have Dr. Lucy Meka. She's the head of National Vaccines and Immunization Program at the Ministry of Health in Kenya. And then finally, but not the least, we have Professor Benjamin Ozuchukwu, who is also affectionately known as BSc, and he is a professor of public health, health systems and policy, University of Nigeria. We have benefited from a number of presentations this morning, right from our introductory remarks given by Dr. Ahmed Ouma. We also have had introductory remarks from Professor John Ataguba, who has highlighted the need for us to look critically at inequities that we see when it comes to vaccine distribution across the continent. We also had a keynote address from Dr. Donald Kaberuka, and he has also talked about the fact that we do need to make choices. We do need to look at the choices and the decisions we take around our response to COVID-19 on the continent. And finally, we also have had two presentations, one by Dr. Mark Jitt, who has talked about evidence and how critical it is to guide us when we take decisions about investments in health. And then lastly, one of the things I picked up from Dr. Madalena Farena is that coverage and speed is of the essence. And unfortunately, in our continent today, we see that we have fallen short of both coverage and speed. So I will start with our first panelist, Dr. Edith Kwasi. What are your thoughts on the comments we've had today from several presenters and our keynote address? What are your thoughts? Dr. Edith Kwasi, please, can you hear us?
Oui.
Okay.
Parfaitement, je ne sais pas si vous m'entendez.
Yes, I can hear you very well. Can you hear me?
Yes, yes, we can hear you now. Can you share your thoughts on it, on the presentations, please?
OK, merci. Je voudrais avant tout propos saluer tout le monde.
Well, first of all, I would like to welcome everyone and thank CDC Africa that gives us the opportunity to talk about this ongoing disease and the vaccines. I must say that all presentations were very relevant. Indeed, COVID has an undeniable impact on the economy in terms of mortality, in terms of active arms of the society that are dying and this unstabilized families, and also in terms of employment. Vaccination is something that should be accessible to everyone, and that's the reason why WHS and some donors have put in place initiatives like the COVAX initiatives and the AVAX for African Union, in order to have a general and quick coverage is the vaccine availability. We received 754,000 doses of AstraZeneca vaccines through COVAX, but after 2 months, we could not have the right strategy to administer them. We had an exchange mission with Ghana, and we could reinforce our strategy with an advanced strategy. In less than a month, the stock was over, but the supply was not regular. And that means that the Côte d'Ivoire had to call upon neighboring countries that gave us some country. We have now over 3 million doses vaccines. First dose vaccines that we were received, and that was given to 5 million. Now you need to be quick. Indeed, once you are vaccinated, you avoid severe forms and death, but supply is key. So I really understand and I agree with all speakers. We need to be vaccinated, but for that we need vaccines to be available. Thank you.
Thank you very much, Dr. Kwasi. You have definitely highlighted the problems we have seen across different countries, depending on our own internal resources and also depending on other external resources. Have you, as you work through this response, have you been able to use evidence at all to help you to strategize and to take decisions around the COVID response? If you can share that briefly with us.
Okay.
Yes. I simply would like to say that Côte d'Ivoire had vaccination as a pillar of prevention beyond the so-called barrier gestures. By the end of 2021, we aim at reaching 30% of the population, so it's 7 million people aged over 18. As I said, we received over 5 million doses of vaccines, but not in a regular way. There were times when there were tensions, and so far, thanks to our country leadership, we could get vaccines on our own funds through COVAX and also through AVAX. And we also had gifts from different countries. We have 4 types of vaccination: AstraZeneca, Pfizer, Johnson & Johnson, and Sinopharm. And that means that we had an intensification strategy in place. Instead of having people coming to the vaccination center, the strategy was an advanced strategy. We go to population, to companies, to stations, to communities. We used artists, famous artists in Ivory Coast, in order to boost this activity. We had sports people, we had any famous people were used in order to boost vaccination. And we were almost faced with a shortage of supply. There was pressure on the market, costs increased, and all forecasts was over. And the risk was that population was discouraged and not get vaccinated. And fortunately enough, recently we've had enough vaccine to keep our strategy going. We focused on the endemic region in Abidjan and in larger cities where the COVID started to increase. We have vaccination peaks in order to reach those targets. And we could see also an impact of vaccinations on death. Because during the third wave, in which we still are, but hopefully we are living it, most people who died were not vaccinated and had severe forms of COVID-19. For your information, from August to September, 52% of notified deaths in the countries were such people. As I said, most people who died were not vaccinated, and the age also decreased. Before it was over 60, where we had a lot of death, still the case, but now people from 50 to 60 see an increase of death in their age range. And these are civil servants, of people in working age. They are family supports, people that are very active. And here I can draw the link between COVID-19 and the economic impact that it might have if we do not leave this as quickly as possible with vaccination, or with also a treatment in reasonable time schedule. That's what I wanted to say. Thank you.
Thank you very much.
Okay.
Yeah, merci beaucoup. This is a very good exposition of the critical need for vaccines. And you have really highlighted this as you've given us what is happening and how you're experiencing the response to COVID-19 in Cote d'Ivoire. Thank you very much. I'd like to quickly move on to Dr. Lucy Mecca. I don't know what your thoughts are on what you've heard from Dr. Edith Kwasi and all that you've also heard from our previous presenters. Are we using evidence enough? Are we basing our decisions on mathematical modeling, simulation models, as we've seen this morning? Are we doing it right? Can you share your thoughts on this, please?
Yeah, thank you very much for this opportunity. This kind of discussion is very pertinent at this time. Looking at the evidence that we have been using since the pandemic began, I could say that in Africa we have been we started off just a little later after the other countries. If you look at Kenya, we started the vaccination in March, and we also had the same challenges that the previous speaker, my colleague from Cote d'Ivoire, has talked about, the issue of vaccine availability. And this has a lot to do with resources, because of course, those who had resources could access the vaccine much earlier. And then we are also seeing that Africa, we are also lagging behind in the percentage of the people vaccinated, possibly not only due to vaccine availability, but also due to resources to deploy the vaccines. And therefore, this kind of discussion is very important at this time for us to look at how we can make a case for the resources that are available, how these resources can be allocated, and also just using the evidence that is there to present a case to both the technical and the political class, so that these resources that can be allocated to COVID-19 vaccination, both procurement of the vaccine and also deployment of the vaccine can be allocated as appropriate without compromising the other health services that are in need. So currently I could say that modeling is still yet not at that advanced level, but it's generally looking at the kind of demographics that are available. And for us as a country, just like other countries, we saw more that mortality was higher in the older age groups. And therefore we prioritized vaccination of the older age groups and also the health workers before the other classes. So going forward, of course, there is also the consideration of opening up to all other age groups. But of course, this is subject to the evidence that is around. If we can present a case that we will have a better economic gain with vaccinating the other age groups, then this will make a case for both the political and the technical class. So I agree with the presenters, and I'm really grateful to have been able to see the kind of modeling that has been done that shows that we need to hasten the vaccination. And African countries, I'm sure if countries that are in a similar setting like Kenya, we are also, apart from grappling with the issue of vaccine availability, we'll also grapple with resources for deploying the vaccine. As my colleague said, the vaccine is being taken out of the facility to groups of people outside the health facility, and therefore we have to deploy additional resources to send the vaccine, to send people for outreaches, and therefore doing modeling even for the kind of costs that are involved in the operational costs will also be quite helpful for the countries. Thank you very much.
Thank you very much, Dr. Lucy Mecca. I mean, you raised important issues about operational costs. You know, so many times when we talk about vaccines and vaccine deliveries and vaccine distribution, we often forget that the operational costs sometimes can be so overwhelming. So it's good to reflect on that, and I'm happy that you have also raised it. We still have enough time to have the thoughts of Professor Uzu Chukwu, BSc, on what has gone on in previous deliberations. One of the things, BSc, I would love you to talk about is the impact of our collaborations with our different institutions, both here in Africa and outside of Africa. How have they impacted the way we have responded to COVID? Do you think we still have room to do more and engage and collaborate to help us get out of this challenging burden of COVID-19 and also other vertical programs that we have across our continent? Please, would love to hear from you.
Okay, so thank you very much, Amma. And I want to thank all the presenters so far for their wonderful exposition and deposition. I agree with all their thoughts. However, my main problem is, despite all the resources we have put in so far, our coverage in Africa still remains low. And so what are the issues? These are the things we should be looking at. So what are the issues? I do know that some countries take haphazard decisions on issues, especially when it comes to vaccine rollout, without concrete evidence. And, you know, some of these things, some of the evidence are there, they're out there. So there is need for us to use evidence for any of the policy decisions that we want to take, I also appreciate the fact that the evidence has to be context specific. So that means what is happening in Uganda may not be what is happening in Nigeria. And so to be able to produce such evidence, we need to fall back to the experts, the modelers, those who are in the field of health technology assessment, to be able to produce this evidence for us, okay? Because the resources are very scarce. And so for you to use the scarce resources, we need to prioritize. And some of these tools, like the health technology, the modeling, they all help us to prioritize. And yes, since the COVID started, we have had a lot of collaboration in Africa with donor partners, with development partners, with institutions, research institutions. But we need to use them more. We need to use them more, especially for evidence production. And then this evidence, when produced, should be well disseminated to countries to use them. So, for example, one of the presenters, I think it was Madeleine, she said it's proper to vaccinate many people as soon as possible. Fine. But how do you do this? So we need evidence to be able to vaccinate more people, as fast as we can. In other words, what kind of delivery strategies are we going to employ in order to reach more people? Is it going to be fixed? Are we going to be using fixed posts? Are we going to be using house to house? Are we going to be using, so what kind of delivery strategies are we going to employ in order to reach more people and vaccinate more people? Which, of course, when you do that, the herd immunity increases. And of course, we begin to deal with the problem. And then, of course, there are a lot of questions that we need to ask. Some of them have been x-rayed here by Mark. Some policy questions that we need to ask ourselves, and policymakers need to ask those questions, and we need to provide answers to such questions. For example, do we need a mix of vaccines, or do we just concentrate on 2-dose vaccines, 1-dose vaccines? You can't sit back and take decisions on this except you do some modeling and health technology assessment. So what is, for example, the cost effectiveness of even vaccinating those who are 20 years and all that? So what is the cost effectiveness? Why do you want to leave those who are at risk and then you vaccinate those who are at risk? All these things, we need to produce evidence to back up our actions. So that's the point, So issues around hesitancy, we are not talking about hesitancy, okay? So you might be pumping in money, but people are resisting intake of these vaccines. So we need to find a way to deal with this. In other words, we need evidence on what we can do in order to reduce hesitancy. And I think some of this modeling, some of these health technology assessment issues will help us to produce evidence that African countries can use to deal with such problems. Thank you very much.
Thank you very much, Prof. This has been very good. And one of the things I want you to talk about briefly before we move on to the other panelists is the issue about equity. So who should get the vaccines? Are we being fair distribution? Who should get the vaccine?
Well, in country, I want to believe that most countries have considered equity in their distribution. Of course, it depends on who you want to target. If you want to target those who are highly at risk, like health workers, then you vaccinate health workers first. If you want to target those who are vulnerable to COVID, like elderly, so you address them first. So the issue of equity and access in country will depend on the context, on the epidemiology of COVID-19 in country, and which means that you must use evidence. The point I'm making is that for you to even equitably distribute the COVID vaccines, you need evidence for that. So you don't sit down and just do that. We have a different population pyramid from developed countries, okay? So we need to take that into consideration when we are taking decisions, when we are planning what to do, okay? So we have a very large, young population base and all that. We have very little up there, this is as opposed to developed countries that have large population up there. So we need to be context specific. The point I'm making is that we should not just import things that are being done elsewhere and then just drop it in our country, because the contexts are not the same. Okay, so we need to be context specific. We need to look at our epidemiology. We need to look at the clinical settings, and then we need to look at cost issues. So these are very, very important. And then we need to collaborate with institutions, okay, who are especially those in those research institutions, those organizations that are well positioned to produce this evidence, like AFIA, the African Health Economics and Policy Association, like the African CDC, like the Center for Global Development, and all that, So, and then institutions, research institutions, I'm sure a lot of them are still ready to help and produce evidence for this. Thank you very much.
Thank you very much for throwing light on this. I'll quickly go to Dr. Kwasi. There's a question from our audience. The question is, recently there have been incidents where vaccines have been donated close to the expiry date. What is the minimum remaining shelf life vaccine donations should have in order for them to be useful for African governments? So I clearly remember that you mentioned that you had to depend on other countries when there were shortages in Cote d'Ivoire. Did you consider the expiry dates as you went around looking for extra doses of vaccines? Thank you.
Merci pour cette question.
Thank you for your question. Well, I think that in Côte d'Ivoire takes into account the expiry date of the vaccines. And as I said, at some point of our strategy, we were at the limit of the shortage of we were nearly in a situation of vaccine shortage, and we didn't want to stop at a time when we had to implement an awareness raising campaign amongst the population. At the time when I'm speaking now, no vaccines were close to their expiry date. We took into account indeed this risk, and we managed for this not to occur. Hence, the strategy adapted to the needs. And it was out of question not to put in place a vaccine activity at all. So we knew that what the expiry dates were, and we took that into account for our strategy. And also, we put in place the units, the mobile units, very similar to health centers that go from one place to another in a van, for instance, through vans. And the awareness raising was in progress. Although I'm not saying that there is no resistance amongst the population, there are resistance. There is resistance, even in the health, amongst the health staff. So we keep doing an awareness raising campaign amongst the population, the associations, the organizations, especially to the most vulnerable populations. But because it's a voluntary basis, we can only do awareness raising. So that was the priority target, and then the secondary target. And then we had all the peoples above 18 years of age vaccinated. So I can guarantee that there is no vaccine out of date that was given to the population. These vaccines were given to the population before their expiry date, because we have to make the vaccination campaign secured, and the government of Côte d'Ivoire is very serious and can't be neglectful with regards to the expiry date of the vaccine. So again, please be reassured, all the populations, all the people who receive the vaccines receive the vaccines in a timely manner.
Thank you very much.
Wait. Also, it was free.
Thank you so much. This is reassuring, and I'm sure this is across board for other countries in Africa as well. I'd also want to speak to Dr. Luti Mecca. As you were speaking earlier on, you mentioned about resource allocation. So there's a wider sector beyond health that has also been impacted by the COVID-19 pandemic. How have you been able to manage resource allocation or investing in key sectors that are able to help you in making sure that the response is making an impact in Kenya? Have you seen any clear shifts in certain sectors suffering because investments are being made in the health sector? And what really has informed this in Kenya? Is there evidence backing these resource allocations at all? Thank you.
Thank you very much for that question. I could say probably as now we are at the second year of the pandemic. So we are at the point where we are at, the society is more or less opening up, and there's a sort of recovery that is going on. But last year, there was quite a hit on the economy, and the government took an approach, a broad approach of addressing the key areas that needed intervention in the economy. Particularly, there were areas that were highest hit, for example, tourism, and generally the tourism sector, which was quite, gives great economic gain for the country, was quite hit. But at this moment, of course, the issues of lockdowns and the curfews also had quite an impact on the economy. But I could say at this point now we are on the road to recovery. We've just come out of a curfew, lifting up of a curfew just a few days ago. So we are looking forward to recovery. But as I said before, the resources are limited. So we cannot really say that we are where we wanted to, where we are at the optimal place that we need to be. There's still a lot of need for resources in various sectors, including health itself. There's quite a big need in health because not only COVID not only affected just COVID alone, but also other health services were affected as people moved on to address COVID. And also you find that even health-seeking behavior for other diseases changed because of COVID. So all those are being addressed. The issue of essential services is also being addressed through various bodies in the health sector. And the government has also set up ways of getting back the other sectors to recovery, despite the limited resources that we have. Thank you.
Thank you very much. And this really ties into what we heard from Dr. Majid about the WHO approach to make sure that health is really in all sectors. So there were two more questions that came through. I will read them out, and then if anyone on our panel or outside our panel can give us answers, please raise your hand. We just have a few minutes to wrap up this particular session. So this is the first question. It says, COVAX is struggling to deliver. supply of COVID vaccines in African countries is low. How much vaccine could African countries buy without jeopardizing budgets for essential services? And finally, it says, do policymakers in African governments have access to evidence they need to make good decisions on COVID vaccines? What could be done to better support our policymakers? So this is an open question for all our panelists and also those outside of our panel. Please, anyone, feel free to answer this as we wrap up this session. Thanks. BSc?
Yeah, well,
okay.
Thank you very much. Yes, I think we don't have enough evidence to make policy decisions. And that's exactly the point I was trying to make, that we need evidence on what to do. And the economic modeling, health technology assessment will enable us produce such evidence. And then when that is done, of course, once the health technology assessment is properly done, because it is a process and you need the policymakers to also be embedded in it. Once that is done, the evidence produced will be easily used by them to make decisions. So that would be my, and then again, that speaks to the first question, okay, how much do we need to purchase? That is a question that health technology assessment will produce an answer to. So we need to really go back to that health technology assessment and then produce, with these kind of policy questions, produce answers to this type of policy questions to help us roll out vaccines properly. Thank you very much.
Thank you very much, BSc. Well noted. Any more answers from the panel or outside of our panel? Otherwise, I think we'll be wrapping up this session and I will hand over to Dr. Umar. Before I do that, I would like to say a big thank you to our panelists. It's been a great discussion. We have taken note of a lot of what you have said and shared with us. We see the critical burden of disease, not just from COVID-19, but also other vertical programs, HIV/AIDS in Africa, and so many other health challenges that we face, and also the double burden of disease and the importance of making a case for investing in health. And so this is really critical. And I'm thankful that you all joined us to make this discussion very fruitful. Thank you so much.
Thank you very much.
Excellent, excellent, excellent panel. Excuse me. And a very, very, very good session that we've had today. It's not possible to summarize it because so much has come out of it. But if there are two messages that I really would like for our participants to go away with, is that we must do things using evidence. We must do things using evidence. This is one. Second is that the health economics part of COVID-19 is not being discussed enough. We are talking about so many aspects of COVID, but not the health economics part of it. And I think at this particular webinar today is the beginning of a conversation that will continue. From us here at Africa CDC, we are committing to do that. And we are looking forward to working together with our colleagues from, I mean, today we have co-hosted this with both CGD and AFIA, and we hope that we'll be able to continue this conversation with you as partners so that we can place the whole area of work of evidence on the table firmly. That way we can be able to guide our continent to make decisions that are solid and the outcomes are going to be to the benefit of this great continent. So I thank you, all of you, the panelists. I thank you, our keynote speaker, Dr. Kaberuka. I thank you to our expert presenters. I thank you, our interpreters who have made sure that we can understand each other. Those of you who have attended this session on the different platforms where it is being broadcasted. And behind the scenes, there's been a tight group of colleagues who have made sure that this meeting has taken place. You know yourselves. A very, very big thank you from me, from Africa CDC, from CGD, from AFIA, and we are looking forward to the next session. Have a very good evening, good morning, good afternoon, and please stay safe. If you have not been vaccinated, please get vaccinated. If you have been vaccinated, take care of your neighbor, your friend, your family member who is not vaccinated, and convince them to go and get their jab as well. Let's do this together. I thank you, and this meeting is adjourned.
Thank you very much.
Thank you very much. Thank you. It's been great.